changed over a period of years. And today, Dr. Pal is going to talk to us about how to crack the newer system of OSCE, which is what is the new version of the OSCE that tends to be put up as the cases in the examination. So over to you, Professor Pal, to tell us about the new system of OSCE.
Thank you, Dr. John Mukhopadhaya. Without wasting my time, just I want to share my experience. Now, the OSCE is the integral part, as Dr. John Mukhopadhaya is highlighted. Now, the little bit form has become changed in OSCE. So, in all national examination, what they consider, the OSCE should consist about the 60% very easy type. Their questions will be very easy, and that depends on the clinical concept, clinical examination, clinical experience. That is the power of observation, decision making, and also the management options. This 60% is consisting of that. So I will start my topic from an easy one. So everybody can diagnose, but there are some questions that little become tricky and critical. So very careful and understand what should be a complete diagnosis. So 60% will consist of that easy type. Now, among the 40%, 20% will become intermediate type, of which there will little bit some knowledge is required. So if the candidate is not very aware of that particular topic, they will be difficult to answer that one. And the last the 10 to 20% will be little bit difficult, and therefore those who want to have a higher marks, it requires some experience, some knowledge, as also some recent advances. And preferably as of now, this OREF Foundation, they are trying to help the students through this program. So we'll consider on the questions of the previous examination. So we'll simulate the questions and we'll discuss about how we will crack those. Now, this is the questions. It is, you can see here. So a 35 years old male presented with sudden onset pain in the left hand following fall on the motorcycle, treated conservatively, including the plaster slab. So you can see the radiograph. You can easily understand what is going on. So these are sorts of questions it is asked. So in my this lecture, so what I tried, so I kept all of the nearby questions which is associated with this sort of problems. So that it will comprehend and understand how to complete a topic. So yeah, it may not complete all the questions. So how far we can go, we can discuss. So this first question is identify the injury. Next is classification. Next is mention the method of conservative management. Next, explain the factors which for possibility of failure for conservative treatment. So this requires some knowledge. And is the method of immobilization, as you can see here, which is correct or not. So that comes from the experience, and we have to justify the explanation. So everybody can also see this is the problem, as you can see here. This is the metacarpophalangeal joint. Second, this is of index finger. It has become so. If everybody can understand, this is a dislocation. Is a dislocation. It is a dorsal dislocation, as you can see here. This is active. So this is a dorsal dislocation of the metacarpophalangeal of the index finger. So this is the complete answer. If you understand this, if it is a dislocation, we'll get half marks. Okay. So we have to understand which one is which finger it is. So you can see the AP view. See this. It is little bit. The alignment is abnormal. So it is an index finger is the most important. Though the view is not very correct, it requires some little bit oblique view, more oblique view. So classify the injury. So classification, how do you classify? It is a simple classification, simple dislocation, or it's a complex dislocation. Next, the method of conservative management. So as you can see here, so it is conservatively treated. So basically, it's a dorsal metacarpophalangeal joint dislocation of the index finger is the complete answer. Next is you have to classify. It is a simple or the complex dislocation, depending on the irreducibility, clinically irreducibility due to the interposition of the soft tissues. Now, what are the soft tissues, the interposition? So most component, it is the volar plate or the palmar plate, and the stabilizing ligaments of this metacarpophalangeal capsule. See this volar plate, which is so this is the proximal phalanx, and this is the metacarpal head. it is basically it is a dome shaped, and see this sort of sagittal balance is going on, and see this volar plate. This volar plate is firmly attached by fibrous or the osteofibrous ligaments with the base of the proximal phalanx, whereas its metacarpal side is very weak. So this is it is almost a membranous type, and it allows the hypermobility of these of the metacarpophalangeal joint. All of you know what is the movement of the metacarpophalangeal joint? It is a flexion is 100-degree, and this that 10 to 15-degree extension. So this sort of extension and flexion, how much this hypermobility that will allow on this condylite joint over this almost condyle shaped of this metacarpal head. So this is a volar plate. So it is a hyperextended, it's a fallen outstretched hand. There's a chance of rupture of this from the metacarpal sides, and that can be interposed in between the bones, and that can lead to irreducibility. So that leads to complex dislocation. Now, how to maintain, how to conservative treatment, how to reduce this? So first of all, you have to flex the wrist. So why to flex the wrist? See the deforming factors. Deforming factors is the lumbricals and the long flexure tendons. So once it is dislocated like that, once it is dislocated like that, just a minute, it's not. Once it is dislocated like that, see the finger flexures are very much stressed. So it and the lumbricals, which is attached on the lateral side, that because they're very much stretched about that because the deforming factors. So that will prevent the dislocation. So we have to keep the wrist flexed to make the flexures relaxed. Push the distal part. See that push the distal part like the proximal phalanx and against the metacarpal heads like this. So the most important message is never extend and give the traction on this, because this maneuver that create the space so that volar plate goes inside it. So that is the most important. And this what is the structures preventing this simple conservative treatment? That is relocation, that is interposed structures and the deforming forces is already discussed. Now, which position it should be mobilized? So this should be functional, and a metacarpal joint should be flexed 30 to 70 degree. As you can see here, is the metacarpophalangeal MCP joint is extended. See the collateral ligaments is relaxed, whereas if it is flexed, it is become stretched. So if it is at all becomes very much stiff about, so it becomes very much stiff in its longest length, and that will lead to less stiffness once it starts mobilization. So it should be immobilized in at least 30 to 70 degree flexion. So this is the next. If this sort of problem occurs in a immature patient, suppose this a child is presented with a sudden onset deformity following playing, similar type of questions it is going on. You have to identify this is basically it is a dislocation of the metacarpophalangeal first metacarpophalangeal and thumb. Clinical signs. So see, this is the hyperextension. There's a palmar dimple on the palmar side, and there's inability to flex. Now, classification is the same. It is a simple classification of the complex dislocation. Reduction technique is almost same. You have to flex the wrist. You have to keep the interphalangeal joint flexed, to keep the long flexures relaxed, and then you have to push the proximal proximal phalanx towards the volar side, as it is a dorsal dislocation. In dorsal dislocation is the commonest, so that we have to push that to the opposite side against the metacarpal head. Now the management technique of ulnar collateral ligament is mostly injured in case of thumb, and it may be acute here or it may be chronic attrition rupture. So in that case, there are different types of terminology can be used for this. It may be scarred thumb, gamekeeper's thumb, but the most important, if there is a complete tear of ulnar collateral ligament, so that is known as the Steiner's lesion, and where there is a possibility of decision of this ulnar collateral ligament proximal to the adductor aponeurosis. So that is the most grave situation where the only surgical option remains. So how do what are the approach on this ulnar collateral ligament of the thumb? So you have to test the clinically, you have to test the stress test. So you have to check whether it is a firm endpoint or a soft endpoint. So, and also you have to check the instability. If the firm endpoint is present, that means it is an incomplete injury. You have to make the conservative, whether thumb spica cast or splint can be used. Thumb, that is a thumb wrist splint. that should be used for 2 to 6 weeks, depending on the severity and the age. Whereas there is no firm endpoint, or there's an unstable situation. Unstable situation means there is a 15-degree difference of the laxity in comparison with the normal side, or more than 30-degree laxity, or there is a radiological asymmetrical joint space. So in that case, operative intervention is required. So this is the one. Next, another case is there's a 25 years old football player who is complain of pain in the ring finger. This is after a game. So identify the injury with explanation. This is the questions. Now identify the abnormality in the radiograph. Next is the mention the relevant clinical test which is required for confirmation of the diagnosis. So this is all will come from the clinical examination. Next is the position of the immobilization. So and whether this position this can be used, whether it is done right or wrong, what should be the ideal immobilization? It is already discussed. What is the classification and is the management? Now see, so you have to understand what is a normal hand, this texture. So it is a normal hand. So this is the resting position. If we check the hand of any person, whether he is sleeping, so this is the normal the attitude of the hand, where there's all the fingers are flexed, where the little fingers are maximally flexed, and the index finger is relatively less flexed, and thumb is at right angle. See, this the plane of the nail. It is at right angle to the plane of the index finger. So this is the normal attitude of the hand. And if we check this, if we make a straight line extending from all the fingers, that will come at the center of the base of the thinner eminence. Now this is the normal tenoracing effect. This is also very important. So important phenomenon. So if we make a flexion, if all of the audience can check in this hand. So if we make wrist passively, you can make a wrist dorsiflexion. So there is a passive, there is a automatic flexion of the fingers. If we make a extension of there's palmar flexion of the wrist, there's automatic, there is a natural finger extension. This is a normal tenoracing effect of the flexure tendon. So this is most important. Another important concept, what is the position of ease and position of function of the wrist? So this is the position of the ease. So if we we're not engaged in any work, and if you examine any hand of any person, they will actually keep their hand in this manner. This is basically this is palmar flexion of the wrist and the extension of the fingers. This is basically the position of the ease. But this is a non-functional position, because the functional position of the wrist is 10 to 15-degree dorsiflexion. So basically, this is basically, if you ask to make a firm fist, if you make a firm fist in this manner, all the fingers can be flexed, but the ring finger cannot be flexed. So basically, and there is a painful. If you check this, there is a pain on the flexure as a palmar aspect of the ring finger, just opposite to the base of the distal phalanx. Basically, it is usually seen in the rugby players or the football players, where another known as a jersey finger, where somebody holds the jersey of a player, and that player is receding away, and the person which holds the jersey, that means there is a forceful extension is going on against the flexed fingers. So as the flexor digitorum profundus, these are the long flexures, which is the powerful flexures of the fingers, and the main tendons are requiring, which is a response for the grip. So once they make a firm, powerful grip, so using this flexure digitorum profundus, and there is somebody is trying to make a forceful extension on a flexed fingers, there is a chance of rupture of the flexure digitorum profundus, that is insertion, and that is basically it's known as the jersey finger. So if you see this hand, so this is basically the oblique view of the hand in a resting hand. So in the resting hand, all of you know, so I already told, see all the PIP and the DIP joints should be flexed. But see the ring finger, it can be relatively extended if we consider if we compare it in its congener, that is the little finger. So this abnormal radiograph shows there is an abnormal extension attitude of the DIP joint of the ring finger. Now mention the relevant clinical test. You have to palpate we have to test the flexure digitorum profundus tendon. So how to test the flexure digitorum profundus tendon? So that is the test. There is a 3-point method. You have to hold it. You have to two finger against the middle finger and the proximal middle phalanx and the proximal phalanx. Another fingers over the PIP joint and ask the patient to extend the DIP joint. That is one method. Another method, you have to fix the middle phalanx and the proximal phalanx against a double, and then you have to ask to extend the DIP joint. So this is the test of the flexure digitorum profundus tendon. Now, another question is mention the relevant clinical position of immobilization. So, position of immobilization is already discussed, and if we require, if it is a diagnosed as a jersey finger, main treatment is this surgery. So, if you wait for the surgery, so during the temporary immobilization till waiting for the surgery or post surgery by reconstruction, we have to use the plaster, the dorsal buckling splint. So basically, the dorsal buckling splint is a heat moldable thermoplastic splint which rests dorsally on the hand. So basically, our aim is to prevent the full extension. So we have to keep the dorsal side, and the wrist should be a 30-degree flexion. MCD joint should be 70-degree flexion. Why 70-degree? I already discussed. And the IP joints or fingers should be in full extension. So there should be no hyper extension. This is most important. So this is the test of this is dorsal buckling splint that can be used. And the classification is the Lady Packer classification. I'm not going into detail. There are 5 stages. First 2 stages is the complete soft tissue, that is a tendon type, only tendon injured. And the last 3 stages is basically bony injury. So this this is the bony flex that can pass through the stage pulley 4 or the pulley 5 or pulley 4 up to 3. So this is the ideal indication for surgery. Now, surgical management if it comes to the 3 weeks, it should be surgically treated with the help of the Bunnell pull-out suture technique, suture anchor. These are the options. And repair of the tendon with the incorporation of the polar plate. For late presenter, these are the options. These are the DIP joint orthodesis or the tenodesis or the stage tendon reconstruction. Now, see, this is the another case. See this. So this is the video is going on, as you can see here. They describe the deformity with significance, which test is being shown, and they mention the steps of the test, and they mention the correlation of this clinical test with the pathological application. This is a 45-year-old male presented with this deformity following injury over the forearm, treated by plaster for 4 months back. See the deformity. Deformity is basically, which is a claw hand, but we have to describe the deformity. So what is the deformity? So the wrist is I'll show you again. See the deformity. See the deformity. So the wrist is flexed. This is a hyperextended MCP and the hyperflexed of the PIP and the DIP, and also the thumb is at the same plane of the palm. And which test is being done? This is basically it's a Volkmann's test. Remember the spelling. I'll show you what is the spelling. If you miss one N, you have to miss whole number. So the Volkmann's is the MANN. So it is a Volkmann. Next, they mention the steps of the test. Now see this is a Volkmann's test. So this is already I've discussed. Volkmann's test. First step is forearm should be pronated. Hold hand with one hand and to keep the wrist neutral position, dorsiflexion, and the palmar flexion. At 3 position, we have to check the extensibility, that is whether the fingers can be straightened by keeping your palp to palp, your another hand to be kept on the palp of your finger, and try to straighten the bent fingers in this neutral position of the wrist, dorsiflexion position of the wrist, and the palmar flexion of the wrist. So how to correlate with the pathology of the clinical with pathological correlation? Basically, that is a fixed length phenomenon. So this is the most important. I don't want to discuss on this. Basically, the most important is if there's a contracture. Basically, it is commonly due to contracture of the flexion muscles. But if the extensors are all also involved, wrist should not be flexed, but should be neutral position instead of palmar flexed. What is the differential diagnosis? Basically, it's a Volkmann ischemic contracture, or it may be tendon tethering or the adhesion. Now, what is the management? If it is a mild to moderate management, you start with the physical stretching, followed with the help of the serial plaster, followed by the Volkmann splint. Again, there is a MANN. It is either a static splint or a dynamic turnbuckle splint. So, when we discuss about the orthosis and prosthesis, we'll show what is the dynamic turnbuckle splint that can be used if it is sufficiently corrected by conservative method. Whereas in the severe and refractory patients, these are the complete answer. This is a muscle or tendon slide procedure with neurolysis of the median and or the anterior interosseous nerve at three sides: Lacerta fibrosus, two heads of the frontal teres, and the carpal tunnel. So there's a long incision to be given from above down to give sequential release from one by one like that. So there is another option is the tendon lengthening, and another issue is the bone shortening. So these are the management. Now, these are the questions may be asked. So that is I've kept it really deliberately. What are the causes of vulvar ischemias? There's A, B, C, D, E, F, and I. So A from is animal bites. B is very common. A is relatively uncommon. B is for bleeding inside the compartment, burns, and the tight bandages, severe compression, dressing, tight dressing, excessive exercise emboli, fractures. That is the supracondylar fracture, fracture of the forearm, arthrogenic injection, and surgery. This is the important information when we do the fasciotomy. Mostly the clinically, we should be done within 48 hours. If it is the facility is there to measure the intercompartmental pressure, it can be measured with the help of the tonometer or the near infrared spectroscopy. Sometimes it is asked in the examination. Now, this is another video. You can see that is a very easy one. So mention the exact orthopedic diagnosis. Orthopedic diagnosis, not a colloquial, that is a static diagnosis. So it is a stenosing tenovaginitis of the long flexure tendon of the wrist, of the thumb. So stenosing tenovaginitis of the long flexure tendon, that is a flexure pollicis longus of the thumb. So this is the complete answer. We have to identify the exact anatomical structure, this cause and victim. Another is this cause is same like the pediatric patient, and two clinical signs mentioned the outline. So see, this stenosing tenovaginitis I already told, cause is a thickening of the A1 pulley, fibrous flexure sheath. So what is the victim? It is a long finger flexures. For the adult, so basically defect is in the pulley. Whereas in the pediatric, it is not in the defect in the pulley, whereas it is on the synovium of the tendon. So basically, it is a notus node where there is a faulty collagenous degeneration and synovial proliferation of the tendon. So that can be usually respond with the conservative treatment, that is a stretching by the mother, hourly stretching, and that can be used. That can be treated by the hyperextension splint, especially at night, 6 to 12 weeks. For adult, we can use the local steroid. For the refractory case, we have to use this surgical release. Now, what are the signs is very common. That's we have to seek the tenderness on the palmar aspect of the base of the thumb, and there's a nodule over the A1 pulley on the palmar aspect. Now, this is a very easy diagnosis. There's a 45-year-old lady presented with this technique, with this deformity following packing her bag. It's the same thing can happen during the bed making. So basically, it is a deformity is basically the mallet finger deformity. Now the classification is the bony and the ligamentous mallet. So ligamentous mallet is prognostically bad than the bony mallet, and it requires extension splint for 8 weeks, followed by the night splint for 4 weeks. Bony mallet, if it is undisplaced or minimally displaced, that can be treated by the extension splint for 6 weeks. If it is a displaced with large fragment, more than 50%, or DIP subluxated, it requires operative fixation. Now, this is another case. So this is a 15-year-old boy presented with this type of deformity of the left elbow with painful restriction of the elbow motions for the last 7 months following significant elbow trauma. Now, the question is, mention is 3 clinical finding in 1 to 4. So this is the 1. You can 2 see this is the this is basically patient is in almost anatomical position, though it is not a true anatomical position. Patient should be asked to stand in an anatomical position to check the deformity. And you can see here it is forearm is deviated outside in respect to the arm, but whether it can be called as a cubitus valgus or not, be very careful. See the 4-1. This is the extension, whereas this extension is normal extension is blocked here. You can see here, so it cannot be termed as a cubitus valgus deformity, but instead, see the full when the forearm is fully supinated, this extension is blocked. Where it's fully pronated, it appears to become fully extended. So basically, it is considered. It may be considered as a stiff elbow, See, these are the flexion is also terminally restricted, and then the extension also. So the terminal extension is restricted, terminal flexion is restricted, and also see the full supination. Full supination is not possible here. So you can tell this three clinical findings. Don't comment on the cubitus valgus. So you can tell that we don't comment on cubitus. Cubitus valgus it is a true coronal plane deformity, but see that it is a biplanar deformity. So you should not tell it's a cubitus valgus. Now mention two important clinical tests. So it is a cubitus valgus. What is your two possible clinical diagnosis? So what are the possible clinical diagnosis? Most important clinical diagnosis is there is a non-union or non-united or malunited lateral condylar fracture of the humerus. So what is the important clinical test? We have to palpate the distal humerus to check the supracondylar ridge thickness, compare the thickness on the medial supracondylar ridge and also the lateral supracondylar ridge, and also the three bony point relationship where the lateral arm and the transverse arm should be increased, but the medial arm should be normal in comparison with the normal side. Okay. And another important cause is differential. See, these are two possible clinical diagnoses. First one is the non-united or malunited lateral condyle. Another important is the Monteggia fracture dislocation of the that is a fracture of the proximal ulna, dislocation of the radius. So these are the two clinical diagnoses. So another important clinical test, you have to palpate the radial head also, because if it is a malunited, it is very difficult to understand clinically determine the malunion of the proximal ulna. So that is why this test. See, third question, which clinical test is being demonstrated in figure 5? So you can see here, this is the basically this a table test or the ruler test, where the whole of the patient is asked to sit on this on a stool by the side of a table. So keeping his whole of the subcutaneous border of the ulna over the table. Same test can be done with the help of a ruler. That is a 1 foot ruler there, and asked to touch the highest point of the olecranon and also the ulnar styloid. So because of the ulnar bowing, this 2 point, highest point and the ulnar head, ulnar styloid cannot be touched with a straight line. So, but if it is a malunited, then it can be possible. So if it's a normal one, so there is some gap will be visible on attempt of doing that. So, but if it is a malunited, there is no gap should be visible. So that is so that suggests, this test suggests this is the abnormal ulnar bow, that may be the absence of the ulnar bow, that may be due to trauma. So all the questions are all discussed. So this is the radiographer, same patient. So this is that it can be given in a different way. So it is a 15 years old boy presented with inability to carry his school bag following the major trauma around the elbow 7 years back. What is the probable cause of his functional deficit? So you can see here. So this is if it is a straight line along the axis of the radius. If it is AP and the lateral view. So it's in the AP and lateral view. If you see the axis, if you draw the axis of the long axis of the radius, if it is extended proximally, it should cross the center of the capitulum in all views. But you see this, it is going there, and this is going above the capitulum. So there's a persistent radial head, and also see this is the abnormal bowing. Instead of the convexity here, there is a concavity. So this is a malunited Monteggia fracture dislocation. So what is the probable? The question is, so what is the probable cause of his functional deficit? So once he carries his bag, so what is happening? So there is no support is going on the lateral side. So basically, it is a posterior lateral instability or postlateral instability, as that's radial head, which is supposed to give the stability on the lateral side, is doesn't provide the stability. So that is that. Another, identify the 3 radiological features. So this is one radiological feature is I already told. There's the long axis of the radius line along the long axis of the radius. It should cross the ulna, cross the capitulum. It is here. It is abnormal. Next is the ulnar. See this line. So this malunited proximal ulna, dislocated radial head, and another important is this is the capitulum. Capitulum. See, this is normally should be a dome shaped. It is also abnormal. See, this is the capitulum. Capitulum is should be dome shaped. It is abnormal. So these three radiological features. Mention the direct and indirect consequences which can happen in future. Basically, if there is no lateral support, that leads to there's a patient it is very difficult to carry the weight on his hand, and that leads to instability. There's a possibility of recurrent injury, and that can to there is eccentric loading of the cartilage, articular cartilage leads to degeneration of the joints. There's another case. It is a 14-year-old girl presented with persistent deformity of the elbow. There's a similar type of case as you can see here. See, it is operated. It is operated 6 months back and diagnosed as a malunited Monteggia. It is already given in the in the questions. See, this is operated. This the plate is given. Now the question is identify the problem. Why it persisted the deformity? You can see if you check this. It is a normal valgus. This is a normal normal attitude of the limb. Whereas on the operated side, there's excessive valgus is seen. These scars you can see here and see. So what is the problem? Now explain the reason and how to solve. Now what is the problem? Same thing. If you try to make it longitudinal, the axis of the radius, so it doesn't cross. It will cross above the capitulum. So it doesn't cross the center of the capitulum. So that is the problem. You can see here in APV type simulus, it is in place, but in lateral view it is definitely it is out. So that is the problem. So that is that may be either it may be reduced, but it is recurrent, but it is be unreduced radial head dislocation is the cause. Now, what is the problem? It is the proximal radioulnar joint may not be addressed during the initial trauma. So what should be the treatment? What should be the treatment? Treatment should be proximal. The proximal ulnar osteotomy is done. But see, it should be much more much more angulated, dorsally angulated or posterior angulated. So through the proximal ulnar osteotomy, bone should be adequately distracted so that the ulnar length should be maintained, so that that will maintain the radial radial head in position, and not only that, the osteotomy site should be adequately angulated dorsally or posteriorly, and the rigid fixation is there, but it is not adequately distracted and posteriorly angulated, so the ulnar length is not maintained. That is why it may be reduced, it may be recurred, or it may be unreduced. So, and the radial head should be either it may be open reduction internal fixation may be required, or with the help of fixation may be required. Now, so this is the theory why it is neglected, because of the abnormal the growth plate. The recognition is very difficult to appear, and then most of the surgeons very much concerned about the ulnar side, so they're very difficult to identify. Now, there is another about from the Bados classification. This another classification is going on. So, if we classify this, we should not miss the proximal radioulnar joint dislocation. So, Bados didn't consider this proximal radioulnar joint dislocation, but Josen, this is the Josen et al. In 2020, they considered the consideration of the proximal radioulnar joint. So, there are 5 types. There's a grade 2. I'm not going into detail. So 3A, 3B, and then the 4B. 4. So these are the inclusion of the is required. Now, neglected Monteggia, what is the treatment? So this is a malunited Monteggia. So there is a refractory dislocation related, and there is soft tissue injury. So capitular facet becomes atrophied and flattened. As you can see in this case, radial head loses its stratiform facet due to the growth without the limitation of the humeral facet, and the dislocated PREJ also results in degeneration of the radial notch, which could block the reduction in future. So ultimately, that leads to change of the alignment and axis of the humeral ulnar joint leads to cubitus varus. That is the explanation why cubitus varus is developed. And this unmatched humeral radial joint becomes painful and eventually develop the osteoarthrosis. So this another question. It is 11 years old boy presented with limping and unable to cross-leg. You can see the patient is unable to sit the cross-leg and provisionally diagnosed as the Perthes disease. It is given in the question. Now, the question is, we have to identify the clinical test and the sign. You can see here, if you check this abduction, normally in pediatric age group, abduction should be at least 45 degrees, whereas this abduction is only 30 degrees. So the abduction is restricted, and when the patient is asked to squat or sit cross-legged like this abduction is further more restricted. Patient is unable to sit like that. So what is the problem? So patient can lie down on this, but when patient cannot sit on attempt of flexion, this sort of abduction is further reduced. So what it suggests? This suggests there is some sectorial defect. So there is a defect in the anterosuperolateral aspect of the femoral head, which remains outside the acetabulum, that may be deformed due to biological plasticity in Perthes disease. So that becomes that which is outside the acetabulum, the anterosuperolateral aspect. So once it is become extended, so that allows some abduction, but once it is flexed, that become parts against the lateral edge of the acetabulum, and the further abduction is further restricted. So this is basically a sectorial sign which suggests there is a structural deformity of the anterosuperolateral aspect of the femoral head. So why it suggests the diagnosis of the Perthes disease? So because Perthes disease is basically it is avascularity, but it is to mechanical defect. So that is why it suggests the Perthes disease. The mention any other similar test to same implication to confirm the diagnosis of the Perthes disease. So Perthes disease with avascularity already told, because the femoral where the ambulatory aspect is already told, is basically the basis of the sectorial sign. Now another test is the change of the internal rotation in flexed hip. Basically, in Perthes is what happens, it is a mechanical restriction. So it is the restriction of the abduction and the internal rotation, whereas the other movement should be relatively preserved. So this is a mechanical pattern of restriction, which is common in Perthes disease. Now, these are the stages, are not going into detail. Just I want to highlight what is the plan. Now, we have to check the abduction internal rotation. I have already highlighted. If it is a true Perthes disease, which is already, it's a healed Perthes, so that leads to only the restriction of the abduction internal rotation. But if it is active Perthes, or because of the deformation, patient persists this deformation for long period, or it becomes relatively late onset Perthes disease. What will happen? Because of the this repeated friction, there is a mechanical inflammation in the hip joint, and all the motion may be restricted. So the hip, so you have to keep your mind open. So in hip, in Perthes disease, which is healed Perthes or late onset Perthes, it may present with a painless limb with sectorial restriction of the restriction of the range of the motion, mostly commonly the abduction and internal rotation, and the sectorial sign positive, or it may present with all movements restricted. So what to be done in this case? So in that case, once we find this, we have to give traction in wide abduction as possible for 3 weeks to keep the inflammation to be settled. After 3 weeks, we again examine it. Now, after 3 weeks of traction and absolute bed rest, if there is no restriction of the other movements except the abduction and the internal rotation, we go by the VDRO, that is the varus derotation osteotomy. If it is the only internal rotation is restricted, then there is varus extension osteotomy. Whereas all motion restricted again, even after 3 weeks, or the abduction rotation, both are all restricted. It is not at all. It is relieved. Then we can make a trial broomstick plaster in abduction internal rotation for 6 weeks. That may be due to faulty the traction, or the parents may not be completely look after by the child during the traction. So that may lead to the abnormality may be persisted. So you have to give some broomstick plaster for in abduction, internal rotation as abduction as possible, as internal rotation as possible. So should not give a much more painful condition, only in painless range for 6 weeks. Again, we have to check. So if there is almost no restriction, we go by the VDRO. If is only internal rotation restricted, we go by the there is varus extension osteotomy. Another, I think it should be the last case, I think, today. This is a 7-year-old boy presented with progressive deformity of the left leg following road traffic injury of the left knee and open right medial foot injury. Okay, so identify the deformity. I think deformity is obvious when the patient is standing in anatomical position. You can see there is a gap in between the malleoli, and there is also abnormal gap between the tibia. So it may be a tibia vera deformity, which is reflected in this radiograph. We can see here tibia is deformed. It is a varus deformity. So mention 2 clinical methods for diagnosis and assessment of the deformity. So basically, it's a tibia vera. Clinical methods: inspection in anatomical position. We have to give the plumb line test for the clinical anatomical axis measurement, and the flexion test. We have to flex the knee hip and knee, 19 hip at least 60 degree, and the knee at least 90 degree, 60 to 90 degree, to check whether deformity is completely obliterated or not. If the deformity is completely obliterated, it identify the femur is at fault. If it is completely persisted, it is the tibia is at fault. If it is partially obliterated, it is both the tibia and femur. So this is the basis of the flexion test. So, okay. Now, the etiology. What is the etiology? Because it is a previous injury and leads to gradual deformity. So there is maybe a loss of physis or loss of fascial function. That is a sick physis or the fascial arrest because of the bony bar. Because that bony bar should be confirmed by the MRI with mapping. So what are the options? Options is asked. So it is a fascial bar resection, repeated osteotomies, because that can recur even after inadequate osteotomy, or the only give osteotomy, that can recur the deformity. Preferably osteotomy should be reserved after the growth. Epiphysiodesis, chondrodiastasis. Lastly, the limb length discrepancy should be managed. Another important the recent advances is a gradual correction of the deformity and the limb length discrepancy with the help of the Elizarov method, or the modified Elizarov method with the help of the tailored special frame with hex support application. Now, what are the factors which will help the clinician for the management? We have to identify the epiphyseal lesion size. If it is 30 degree or less, we have to go by the fascial bar resection. Again, we have to check whether the fascial defect is in the center or the periphery. I will come how then depending on that we can change our options. But if it is more than 50%, so it is a very difficult to give some fascial bar resection. Then we have to go by the epiphysiodesis. So this is a most important. So we have to use of the MRI to map the epiphysia, the bar exact area of the bar. Another important factor, that is, we have to check whether there is at least 2 years of growth remaining. So if there is a 2 years of growth remaining, so in that case, we have to choose the fascial bar resection. So if the lesion size is 30%, that is 20 to 40% range, or less, and there is at least 2 years of growth remaining, we have to go by the fascial bar resection. If it is an infective process, we have to wait for at least 1 year till the complete healing of the discharge. So these three conditions should be fulfilled before the fascial bar resection. Now, what are the investigations to be? Basically, it's the lateral radiograph of the elbow for proximal ulnar physis. There is radiograph of the phalanges for physis of the distal phalanx, which will suggest if the physis are open, that will suggest that there are 2 years of growth remaining, and we can go for the fascial bar resection. Otherwise, we have to go by the epiphysiodesis or the other methods and the MRI technique. So this is the plumb line test. This is the anatomical axis measurement. So if this is a clinical test basically. So if we start a straight line from the anterosuperior spine, and that will go through the center of the patella, if we it goes further down, that should normally start with the medial malleus. This is a clinical test, and the radiological test is the orthoröntgenogram. So the center of the hip, center of the patella, and should go through the center of the ankle. There is a midline axis division mat test. And this is the plumb line test. This is also clinical test. Is the plumb line is dropped from the tip of the occiput, that will cross the natal cleft, that will fall in the just center in between in the head. So this is the mechanical axis deviation. This I have already told. I'm not going to detail. And this is a bar mapping MRI. It is basically which is the best. If you ask for the best investigating modality for diagnosis of the fascial bar, it is a fat suppressed 3D spoiled gradient echo-weighted MRI. This is a full diagnosis. So this is the radiograph. If it is positive, it is open. That will suggest 2 years of growth remaining. This is the last slide, I think, today's slide. So you have to indicate what are the indication of epiphysiodesis. So I have already told if the fascial bar mapping, it suggests is more than 50% is involved. So you have to go by the epiphysiodesis. Now, if it is a limb length discrepancy, it is 2 to 5 centimeter. We can correct with the help of this epiphysiodesis. Now, it is a central fascial arrest. We go by the contralateral epiphysiodesis, so that we can control the limb length discrepancy. It is a peripheral fascial arrest. This ipsilateral epiphysiodesis. and without the control fasciitis, depending on the situation. And what are the different tools we can discuss later on. So I think we can stop here and we can take some questions from the audience. Over to Dr. Janki.
Thank you very much. Sir, as most of the things you have explained about the upper limb and while we are, yeah.
Thanks, Dr. Pal. That was excellent. I didn't realize I was still muted. A couple of things. When you say epiphysiodesis, today we talk about growth modulation and epiphysiodesis as two separate things. While epiphysiodesis is a permanent closure of that physis, you can do a growth modulation at a certain stage where you allow growth on the opposite side to take place while you're stopping growth on one side. And by that, you hope to correct the deformity. And again, for that, you still need at least 2 years of growth left. So just like for your bar excision, for correction using growth modulation, you need 2 years of growth left to be confident that the deformity will correct. The second thing is opposite side epiphysiodesis is something which is used to correct limb length discrepancy. So if you have one side which you know is going to be short and you know the other side and you calculate the length that is going to be achieved, then at some stage in the growth, you can stop the growth on the opposite side. And here you'd have to use 8 plates on both sides of the physis or a staple on both sides of the physis so that you stop the growth till the opposite limb catches up or this, and then you need to take out the staples, or hopefully the growth is finished by then so that it will not cause further problems with the limb length. Okay.
Thank you.
Sir, we have one question in the chat box by Dr. Pratyush. He wants more explanation on angulation in Monteggia fracture, ulnar angulation.
Basically, as I've already showed it. So this is if we keep it hand over this like this, everybody can like a single ruler. If you use this, normally see this is the gap. You can see the gap. You can see the gap. So in between this, there is a gap in between. So this is a normal ulnar bow. But if it is a malunited, so in that case, you can touch the highest point on the tip of the ulna and on the ulnar stylo. So you can touch it, both the points in a single straight line. So that is the test. By this is my ruler test, you can tell it. You cannot mention the name because, this is the test by which you can easily understand there is a abnormal bowing of the ulna. Now, you can see here the Monteggia fracture is maybe type 1, type 2, type 3. Type 1 is the anterior angulation, type 2 is a posterior, type 3 is a lateral angulation, type 4 is both the ulna and the radius is it is fractured. So it is basically it is asked you how the posterior angulation. I think it is asked during the operation. So so if it is a malunited Monteggia, so normal bowing is lost like this. So normal bowing is like that. It is lost. So that pushes the radial head upwards. So we have to make extend the oblique osteotomy. We can make a slide on this, like make a osteotomy slide on this. So we can gain the length and make just oblique like this. So this is the posterior angulation. Now how to understand what is the angulation? Now basically the angular deformity is because of angulation we require a arrow, isn't it? So arrow requires a 2-arm. Okay, if we make a 2-arm, it is pointing towards the posterior, that is a posterior angulation. If it is anterior angulation, lateral is the lateral angulation like that. So if we make a osteotomy and make a distraction and so there are different names, Zirayama, everything, or there are king osteotomy, different type of osteotomy. Basically, it is a distraction, it is an angulation, dorsal angulation, so that creates a space that increases that recovers the length of the ulna. Ulna is the longest bone and the longer bone than the radius. So if it is a malunited, its length is reduced, so radius is going on, it's dislocated. So as the length is recovered, so the radius gets space to relocate it. So still, if it is a long-standing, there even after the correction of the ulnar length, the radial head is not relocating, then you have to open it. The open reduction is required, and then you have to fix it with a temporary KR fixation followed by the exercise. So that is the concept.
Yes, sir.
So one of the things that you have to understand in any Monteggia fracture dislocation is you can have a fracture and a dislocation of the ulna where it's recognized there's been a fracture, or sometimes you can just get an angulation deformity of the ulna with dislocation of the radial head. So very often these fractures are missed Monteggias. Okay, these so-called angulation deformities which end up with dislocation of the radial head. Obviously, the type 1 is the most common, but you can have type 2 and type 3 as well, where you actually may not have a fracture, but you have a dislocation of the radioulnar joint as a result of the angulation. When you have a fracture, there's usually shortening as well as angulation. Okay, and if you don't get that length right or the angulation right, the chances of dislocation persisting is much higher, or the fracture or the radial head redislocating, even if you've got a reduction, is higher. So on the other side, when you have to correct this late, you need to angulate and distract, and you actually have to do a little more angulation than would normally be there in the ulna to get that radial head back to a stable position. Okay, so you need to get both length and angulation, which is actually slightly more than the original angulation, for the radial head to comfortably sit on the capitulum and not redislocate. And usually if you do that, you don't need to do additional procedures like the Bell-Towse procedure, where you do a annular reconstruction or added K-wires, etc., to keep the radial head in place, which you want to avoid if at all possible.
Absolutely.
So just one question, sir. In pediatric Monteggia, is there any case which can we wait and watch, or it's always that we have to intervene?
So what do you mean by wait and watch in a pediatric
Like, sir,
Monteggia?
sometimes
Because a pediatric Monteggia, the radial head is dislocated.
Yeah,
so how can you wait and watch? You can do a closed reduction. You may not have to operate on everything, but you certainly need to get the radial head reduced.
Okay, sir. Yes, sir.
So there's no such thing as
one thing I should highlight. So there is only there is no question of wait and watch. But if it is a conservative management, maybe we can apply. So if it is just minimally displaced, so in that case you have to reduce it like this by pressing over the radial head. Make a full flexion. If you make a full flexion and fully supinated, so in that case radial head will remain. If it is a minimally displaced, you can pull it. But if it is a displaced one, so it is I think it should be corrected.
And this is also important because in type 1, you need to keep it flexed.
Absolutely.
In type 2, you actually need to keep it extended. So you cast in extension.
Absolutely.
Okay, because so the other thing is that and you need to watch these for redislocations. If you're treating them closed or even open, it's not that you just leave it and forget about it. Always get a check X-ray done at a week, 10 days to make sure that the head is still in place.
Absolutely.
Okay.
So I think we have taken all the questions. So
I think you need to make an announcement of the next 2 weeks.
Yeah. Yes, sir. Next week we will not have any class.
Next 2 weeks.
Yes, sir. Next 2 weeks, and then we'll have a class.
18th of June.
Yeah, on 18th. Yes, sir.
Yeah. So
Yes,
I think I'm going to be out of town, out of the country for the next 2 weeks, and also I think it's really getting hot around in most parts of the country. So maybe you need a break. So we'll restart the series.
You should take a break. You'll be continuing for a long time.
Yeah. Okay. Thank you very much, everybody.
Okay.
Until next week, thank you very much, Dr. Pal, as usual, for a great talk. And till the next meeting, bye to everybody. Okay, bye.
Thank you very much, sir.
Sure.
Thank you, sir.